again to the Only You. Simple talk about complex issues in mental health and mental illness. Here, of course, with Dr. Patino in his studio office. And we're going to chat a little bit today about something I think a lot of people ask about. I know when people find out I work with you, this question comes up a lot. And basically, it's not so much just when to to seek help, but at what level? Or having a bad day, is that something you just, pick up the phone and chat with a friend? Or is it so profound that you need a therapist, or even more so, that you need actual psychiatrists? And how doctors, as a just everyday person, determine their level of need when it comes to chatting with somebody about the problems they're having?
Well, that's. I mean, it sounds like a pretty simple question, but it's really a very profound question because the underpinnings of this particular question are so deeply rooted into our culture, our beliefs, our understanding, our gender. I mean,
Mm,
it is one of those issues that, and even for us as psychiatrists, we really don't think about it very much because most patients that come to us don't knock at the door of the office and say, "Can I see the psychiatrist?" The road to get to the psychiatrist is kind of interesting, and I think that it can engulfs the whole question, right? And one of the main issues on how to decide who do you need to talk to really is guided by how much do you know you, right?
mm,
And how much do you trust? Because the most significant issue with asking for help is the willingness to expose yourself, right? So if you feel and you have the stigma that mental health is a voodoo bad thing that nobody needs to know about, it's going to become extremely difficult for you to talk to anybody, right?
even your friends.
Mm. Anybody, including, I mean, it varies depending on your culture, right? Like if you're Hispanic versus Asian versus African American versus white, each one has their own ways of handling that potential shame, right? And unfortunately, we haven't done a very good job on dissipating the stigma. And it continues to be there, and everybody's responsible. I mean, from medicine, I mean, if it's even difficult to talk about depression and anxiety to your family doctor,
Mm.
right? It's difficult to talk to the nurse. So we usually end up manifesting emotions in different ways, hoping that somebody will get it, right? Uh, and some people resort to using drugs, some people resort to drinking, some people resort to aggression and domestic violence. But underneath, there's this inability to expose ourselves as being weak or defective, right? So when I say we need to be able to understand ourselves and our vulnerabilities, we need to start exploring, I mean, even proactively before we get to that point, in a hypothetical way, right? What if one day I'm so sad that I think that life isn't worth living? Who would I talk to about it?
Mm.
Right? I think that is one of those things that we never do any planning about, right? Um, how am I going to manage my pain when my significant other or my mother or my father die? You know, we don't really want to deal with that until we get to that, until we kind of force, right, into that. So it becomes very important that first we define our trust bubble, our trust
Mm.
environment, right? And that can be a friend, it can be a family member, it can be school teacher, it can be anybody that you know is going to be able to listen in a non-judgmental way. The biggest fear that people have about exposing themselves emotionally is judgment, right? So if we're able to start defining our trust comfort, right, then we have to start practicing. So, for example, if you're in a relationship and you have a significant other, it becomes important that you start practicing exposing yourself, you know. It doesn't have to be about negative bad stuff. It can be as simple as, I had a great day at work. I'm very happy. They were very happy with my job, because sometimes we're ashamed of showing off, right? So we don't want to do too much of the good and not too much of the bad. So practicing becomes a way of exploring, right?
We've talked about the different levels of frequency, intensity, and dysfunction. And it seems that that's a way to kind of like look at this too. If you're occasionally having a bad day or some difficult times, maybe a friend is who you need to talk to. If the intensity level gets pretty high, that it's negatively affecting your day-to-day, work or your relationships, a therapist would be next. And as you said, a lot of people end up in the psychiatrist's office not because they knock on the door, but they're forced there because of a train wreck or some type of horrible thing in their life. Is that kind of a metric, or is that really out the window? Because for one person, the pain of losing a loved one could be traumatic but manageable. For somebody else, it could be a life changing event, and for others, it's unbearable.
Yeah, you see, one of the measures that I use personally in my life and in my practice is what is the level of dysfunction? Meaning, what is the situation doing to my life? Right? So, if the situation is not preventing you from getting up in the morning and going to work and having a relationship that is functional, and you sleep well at night and you're eating okay, but you feel kind of tired and sad because you lost someone, well, you may not necessarily need to see a therapist, right? So you start seeing a therapist when your resources become overwhelmed. So if your resources are overwhelmed, and sometimes we need some external help to tell us that our resources are overwhelmed, right? So by the way, you haven't been sleeping very well. You're only sleeping 4 hours at night. I see that you're kind of shorter in your demeanor with other people. It seems to me that I've seen you isolating, you're not socializing as much. Because when we say about what is this doing to your life, we have to look at three aspects. One is what is it doing to you biologically, what is it doing to you psychologically, and what is doing to you socially. And if those things are starting to get out of balance and your resources and your trust with the people in your environment has not been of help, then that's the time to move to a therapist, right? Therapists are actually trained to identify more serious problems than they're able to take care of. So, for example, a therapist can be very good at recognizing, this, yes, you're grieving, but by the way, you don't sleep, you have no energy, no motivation, no interest, you're starting to think that life isn't worth living, you're having trouble concentrating, you're not performing good at work. Well, that sounds like it's going beyond grief into a severe depressive disorder. Okay. And they may suggest that you go and see your family doctor for medication or a psychiatrist for medication, right? The one that most patients see more often for medication is a family doctor. In the case of younger patients, usually the pediatrician too.
I have a question about that. We've discussed this a bit in the past. The vast majority of people who manage their mental health or mental wellness really not with a trained professional in the sense of a psychiatrist or therapist, but a lot of them times through a nurse, urgent care, or their family doctor. How well trained are those people to truly address this? I had a friend who went to his GP, and next thing you know, his GP's giving him antidepressants. He asked me about it, and I'm like, I don't know if you've been assessed to have an actual issue or not. To be just handed antidepressants, I found a little bit disturbing. He chose not to take them, and turned out, yeah, he didn't need them. But really, where is that? Should we be fully trusting our GPs for this, or should we, if they say, hey, we think you should be on antidepressants, maybe be asking for that consult for a psychiatrist?
I have to say that most family doctors, most pediatricians are relatively well trained on managing and prescribing medications. They're also trained on making good assessments. However, the problem is that they don't spend enough time with the patient. So usually, um, depending on the physician, I mean, there are physicians who spend a lot of time with their patients. Some physicians who don't. But when you start connecting sadness to antidepressants, then that's a problem.
Mm,
because you see, antidepressants don't treat sadness. Antidepressants treat symptoms associated with depression: energy, motivation, interest, concentration, sleep, those kinds of things. So, if the problem is primarily psychosocial and there's no history in the family of depression, the patient's never had depression before, you can be guided by the level of dysfunctionality and suggest an antidepressant.
mhm,
The thing is that because of the lack of contact and time, usually the physician himself or herself are not going to be spending enough time to answer all the questions and to answer all the options. Why is this important? Because the decision of taking an antidepressant is a patient's decision, not a doctor's decision, right? I mean, and maybe I'm old fashioned, but I don't believe that doctors should be telling the patients what they need to do. I believe that doctors have to discuss with the patients their options, and the patients have to make decisions about what options they want based on what they know of themselves and the risks and benefits of the selected treatment, right? But we have, because of the shortness of time that we physicians have ended up spending with patients, we ended up being dictatorial. This is what you have to take. Okay. And I have to tell you, and I tell physicians because I train medical students and PAs and nurse practitioners, I usually tell them that they should never tell the patients what to do. Okay. Because that gets you in trouble, right? We're not decision makers for people. We are experts that provide opinions that patients have to choose.
mm,
Of course, yes, there are situations in which the decision is so obvious, You walk into the emergency room with appendicitis, and the doctor is going to tell you what your options are. I remove the appendix, or you're going to get a bad infection, you could die. Which one do you want?
mm,
But that's a correct way of doing it, right? Versus, I'm going to take you to the OR and remove your appendix. No, doctor, you need to discuss the options with me, and I have to decide if I want my appendix removed or not, right? So those kinds of situations should be most frequently the situation the doctor is dealing with, right? In psychiatry, because we spend more time with the patients and we're listening more, it has become, we're more used to that. Now, you probably have noticed that patients have become very um, attached to their physician assistants and nurse practitioners.
mm,
And there's a basic reason for that, and is that they spend more time listening than the physician, right? So the communication emotionally, either with the nurse or the nurse practitioners or the physician assistant, is deeper than the communication having with the doctor, right? And the fact that that is not the level of authority of our physicians makes them easier for them to open up, you know?
kind of like speaking to your friends, right? There's that level of trust. Back to kind of figuring out where you need help. Are there ways to do online self assessments or things of that nature? Because I do think people, I mean, anybody can fall into a depression. And that, as you said, that's very different than having depression. Being depressed and having depression are different things. Are there resources out there for people who think, you know what, my life's not doing so great. I'm not, maybe they're on that borderline area of functionality. They're still getting through life, but they really haven't made that decision. They don't know. Is there a way for people to, again, privately, because of the cultural aspects, to get some way to assess themselves professionally, and then make that decision based on that data?
Yes, you see, but we have to. I mean, there's sites like, I think there's sites from the Persian Association of America, NAMI, the National Association of the Mentally Ill. The government has sites on the National Institute of Mental Health, where you can actually find and explore different options in terms of recognizing what is major depression, what is dysthymia, what is grief, and most of these things are more related to, again, intensity, frequency, and dysfunction, right? Now, they're not in a continuum. The fact that you're grieving doesn't mean you're going to have major depression. But if you had major depression before the grieving, you may start with grieving, and then the depression takes over. So the management has to be focused on improving the functioning, right? Not on getting rid of the depression. Depression as an illness is a difficult thing to treat that requires a lot of discipline and participation from the doctor, therapist, and the patient. At the end of the day, the ultimate functional responsibility is from the patient.
Mm.
We can do a lot of advice, we can tell them a lot of stuff to do, but if they don't do it, there's nothing we can do. No different than having diabetes and then following a diet, right? The problem in this, particularly in the United States, maybe a little different in other cultures, in other countries, is that we have become enamored with the idea that there's a pill that fixes things.
Mm.
And there are no pills that fix anything. There are surgeries that fix things, there's antibiotics that fix things, but outside of that, no. So antidepressants are not the treatment of depression. Antidepressants, anti-anxiety, antipsychotic are the treatment of some of the symptoms associated with that disorder.
So where does the United States rank in kind of global healthcare systems? I'm curious. Again, we have a mixed culture here. Yeah, we have an American culture, but we have all these subcultures. So you have that. But where does it rank in the world when it comes to this? I'm curious.
Well, the problem with ranking is that it's tremendously subjective, right? Meaning there are a lot of cultural issues, there are a lot of historical issues, there are a lot of social issues, there are a lot of economic issues. Um, so I don't think that there's a valid standard of um, in terms of saying, you can compare apples to apples, right? To some degree, we kind of um, comparing apples and oranges. I think that one of the problems with the United States is that we're a very fragmented society when it comes to the acceptance of mental illness. Okay. So we have certain segments of the population that are very accepting and very empathic. There's certain segments of the population that are very rejecting of that. We have cultural issues like in any country. And you and I have talked about some of those. Men in particular, okay, are very resistant to voluntarily expose themselves emotionally. So it becomes important that we find um, bridges, right? Um, and I think that to some degree, and this is gonna sound very critical, we have become somewhat of a niche, ignorance driven society, right?
What does that mean?
It means that we buy into myths, we buy into quasi delusional thinking, and then we create a whole environment around it, right? And in some cases, dangerous environments, right? You and I were discussing before the meeting the whole idea of guns um, and the culture of gun ownership, and who is supportive and who's not supportive. And the lines are pretty rigid,
Mm.
right? I
Oh
mean,
yes.
there's no bridging of those concepts to the point that each one thinks that the other side is delusional, right?
Yeah, Hegel is rolling over in his grave because the thesis and antithesis now are so pushed to extremes, and it's an it's an all or none game that there's never going to be, or it's going to very take a long time for there to be a synthesis that moves us forward. Because in order to do that, both sides have to compromise to a certain extent and meet somewhere else. It's become this really weird all or none game. Um, Mental health, though, that you again brought up the gun world. I find it interesting. As you know, I have a couple friends in from special operations community, and especially the higher end guys, the tier one guys. They've been given a lot of support. For their mental health because of the things that they do, how dangerous it is, and the type of environments in which they operate. And I find it interesting because we had a chat. We all went out to dinner a while back, and for some reason they asked. me these questions, and maybe because I work with you. And I told them, I said, we're at in order for you to move forward and any of your trauma, dealing with your trauma, you kind of have to be the opposite of what you've been programmed to be, right? You're always programmed to be tough, to work through pain, to ignore discomfort and all these other things. I said, but when it comes to your mental health and finding the triggers and the things of that nature that can affect you, you have to be the opposite. You almost have to be super sensitive to those things. Like when you're patrolling, when you're going out to with the bad guys, everything has to be heightened, every input. I said, now you have to do that in a peacetime environment to say, okay, what are the things that are affecting me? What's going to push me toward that area? And be just, again, super super sensitive instead of super 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 tough in a way.
Now you see one of the things with mental health services is that for a very long time in the United States, probably up until the 1970s, 1980s, is a very elitist type of system. You know, the people with money could get access to good mental health services, and the people with very serious mental illness were locked up in state hospitals, right?
Literally, they had insane asylums back in the day,
Yeah.
right?
So since the mid 1960s until now, with the emptying of the psychiatric hospital, we tried to democratize psychiatry, and we went probably a little too extreme, and that created a lot of social problems, in particularly homelessness, right? Because the asylums were open, and there are people who need total care, right? That are not in hospitals anymore. Most what we used to call insane asylums of the old days are now called state hospitals. In most states, hospitals are limited to treating the very dangerous people, right? So we decided as a society that having a serious mental illness, if you're not dangerous to self or others, then you can be free and do whatever you want, okay?
Mm,
Unless you become dangerous to self or others. Whether you're in some states you're severely disabled. But what has happened is that half of the population of homeless people are mentally ill individuals who have chosen not to get any treatment, right? Now, we also have issues related with some increase in suicide rates in some populations, particularly adolescents and the other elderly. When I was in training in the 1980s, the high rate of suicide was what we used to call the West middle-aged male, white Anglo-Saxon Protestant male. Those were the people who mostly committed suicide back in those days. Nowadays, we have a much more diverse cultural environment with a lot more people in the minority groups committing suicide. The adolescent numbers have gone up. The elderly male numbers have gone up. So, because of that, suicide has become an issue. Um, what we need to understand is that the United States, as being the number one, country in the world in terms of money, the percentage of money we utilize for mental health as a percentage of our budgets is pretty low. Okay,
mm,
lower than other societies. But part of the problem is that it's very difficult to. It's one of those problems that money itself is not going to fix. Right? It requires a change of attitude, and it requires a change of political impetus and values. Okay? Because what has happened is, as we have moved over the last couple of generations into everyone for themselves, and you're only valuable if you succeed, we forget that people have values for being human. So if we don't change the humanity component and the empathy and the understanding, our ability to listen, then we're going to continue having these issues, right? So to some degree, the value of humanity has decreased over the last 30 years.
mm,
We don't value humanity as much as we did. And we're falling into the trap of valuing performance as a determinant of humanity versus values, right? So that is problematic. It's just, obviously, we went to the crisis of COVID for the last 2 or 3 years, and that was another. We got kind of shaken, and say, can you look back and understand what's valuable?
mm.
And to some degree, some people got it, and some people didn't.
Yeah, for sure. It's funny you said that. When you see the homeless people, we're in Phoenix now, even up in the Scottsdale area, there's homeless. Um, I find it interesting the language used. It's not, hey, there's a person down on his luck or with mental health issues or with drug addiction. It's, oh, look at those people. It's separate. It's separate from the rest of us. Instead of saying, no, that's a person that's just, in that situation. Just a total lack of empathy, really, on the part of
Yeah,
so
you
many
see,
people.
yeah, one of the issues, Vince, with the advent of increased cultural diversity in the United States and the fear of white people that are being replaced has created a situation of people considering the late 1940s to 1950s as the model to follow for white people, right? The problem with that is that back in those days, I mean, any man could tell his wife to an insane asylum and say that she was crazy and put her in,
Mhm.
right? No hearing, nothing. Now, um, the train has getting off the station. We are not going back to the 1940s and 1950s, but there's still people living in that fantasy,
Mhm.
okay? But that fantasy doesn't fit the reality of what they see every day.
Yeah.
I mean, I wouldn't be surprised some people tell them we should shoot them all, or lock them up.
Yeah. And that, interesting you said that, that 1950s mentality isn't really mental health friendly, right? Like at all. It was either lock them up or you just get on with things. There wasn't
Yeah,
talking to a friend. There weren't therapists. And if you went to a therapist, there was something wrong with you. And if you're definitely in a psychiatrist, there's really something wrong with you. And there was social ostracization.
yeah, and wealthy people were going to see wealthy people, white wealthy people were going to see the psychoanalyst, right?
Hmm.
Spending a fortune on something that we eventually found out wasn't very effective.
I find that a bit amusing that it took that long, but I guess someone had to get paid for it. Uh, but but back to our original theme, friends, therapists, and psychiatrists. It really, like I said, depends on the level of dysfunction, and of course, as we've talked about before, if you're talking to a friend, you're having an issue. If you're talking to a therapist, you may have a problem. If you're talking to a psychiatrist, you may have something closer to an emergency. But we want to avoid the next step beyond that, and which is a crisis that forces you to either see a psychiatrist, a therapist, or somebody else. Is that
Correct.
correct?
Yeah.
So use the people around you. Use online resources. Use us. Ask questions on our live chats here. And if you feel that dysfunction is getting to a level where it's negatively affecting your life, maybe take the next step to a therapist and then ask that therapist. Be open with them. Be honest. Be understanding. Listen to what they have to say. And if they say, you know what, I think you need to take the next step. Don't see it as a slight on you. You've said this many times. It's not a character flaw. May just be genetics, may just be how you're built. And like diabetes, it's something that has to be managed so that you could live a fruitful life and long life.
Hey, thank you.
Thank you very much, doctor.
We'll see you next week. Take
Take
care.
care.